Hello, welcome, and thank you for joining today's webinar titled OCR Guidance on Patient Access, What You Need to Know. I'm Bud Walder, Vice President of Sales and Marketing here at DataMotion, and today we're pleased to welcome back our friend Chris Apgar. Chris is a security and privacy expert, a certified information systems security professional, and the CEO of consulting firm Apgar and Associates. Hi, Chris. How are you?
I'm doing fine, Bud. Thank you.
Great. To set the stage for Chris, the HIPAA rules require that healthcare providers give individuals the ability to view and receive copies of their medical records in a timely manner and in an electronic format whenever possible. So over the next 40 minutes or so, Chris is going to dive into the recent guidance issued by the Office of Civil Rights, who oversees HIPAA, on patient right to access their health information, and he'll kind of parse out what you need to know, not only to meet HIPAA requirements, but also to engage and serve your patient. So before we get started, just some housekeeping. Please note that you can ask questions anytime during the webinar using the BreakTalk chat function, and that's below the presentation window, and you may have to exit out of full screen mode to do that. And Chris will respond to those questions in the time available after the presentation, or if they pop up at a timely in a timely manner or a good spot during the presentation. Also note that you can download the slide deck itself from the attachments button in the webinar console as well. So with that, I'll turn the webinar over to Chris.
Thank you, Bud. I'd like to welcome everybody to today's webinar. I'll be going over the OCR guidance that was issued, I believe, about a year ago on right to access. A little bit first to start off on some sort of a refresher on what are all of the privacy rights of patients, and split it out between what was there in the rule to begin with in 2003 and what was added to it in 2013. So just look at it from an overview perspective. We'll talk about the right to access. We'll talk about designated record sets. What is it? What is OCR defining it as? Then get into more of the actual process, as OCR says, okay, somebody requests it, you provide copies of something, what are the fees, what can you deny access for, including those that are appealable, and then a little bit about the designated record set copies to third parties, which was something that was new with the omnibus rule. And then we'll have time at the end for question and answer. Now, in 2003, when the privacy rule was enforceable, these were the rights that were included in the privacy rule at that point in time. The first one was, of course, what we're talking about today, which is requesting a copy of your medical record or designated record set, right to request amendments, the right to request alternative communications, rights to request restrictions, the accounting of disclosures. And of course, we're in the United States. We want to complain about anything at any time. So patients and health plan members can complain to covered entities, and they can also complain to the Office for Civil Rights. Now, what changed in 2013 is they added the ability for patients and health plan members to request an electronic copy of the designated record set. I'll go into that in a little more detail. The right to opt out of fundraising solicitations, which has to really be treated just the same way as an authorization. So in other words, if they opt out, you really have to honor that. With request for restrictions, that was changed to basically say if the patient comes in for care and they pay at that time up front and say, hey, don't send this to my health plan, you have to honor that unless there's some statutory requirement like under Medicaid, where Medicaid's the payer of the last resort, where you have to, from a regulatory perspective, report that to Medicaid. That's an exception, but any other time, like if somebody has a commercial carrier, then if they pay in cash up front and say, don't tell my insurance company, you can't tell the insurance company. They have the right to an accounting of disclosures, and that was updated from the very beginning, and basically said they can have a copy of, or they can have an accounting that includes even activities that were included in treatment, payment, and healthcare authorizations. First rule came out, the draft came out, and nobody was happy with it. And then not that long ago, OCR said it's not even on our radar. We're not even gonna worry about a rule at this point. And so that's something that's, it's out there, it's in statute under the HITECH Act, but it's not something that the regulators are going to do anything about anytime soon. The other thing that came out of the omnibus rule was the ability to request that a designated record set be sent to a third party without charging that third party any more than you would have charged the patient. So that's sort of a then and now type of thing. And a little bit an overview on the right to access itself. So what happened I'll give you a little history. When they did the phase 1 audits, one of the biggest things that they found was an issue of supporting right to access medical records or benefit records. And so when phase 2 came around, that was one of the areas they specifically concentrated on, where OCR went out and said, I'm going to show, from the privacy rule perspective, we're going to look into notice of privacy practices, and we're going to look into right to access. And then around the same time, they issued the guidance that said, here's our guidance on what you need to keep in mind. So basically what it said is the privacy rule, it requires you to provide this copy to the individuals, and that's more than just providing a copy, because patients and health plan members have a right to a copy, which you can charge for, and they can ask to view their record. In other words, come in and sit down and view their electronic health record. I have run into issues myself personally when I asked to view my medical record, and I was told that, well, I couldn't because it was in the electronic health record. And it was sort of like, well, no, that's not an excuse. You got to find some way to show the patient their record if they want to see it. And it's one of those where, as long as you're storing it as a covered entity or a business associate on behalf of a covered entity, you need to be able to provide copies of it. So if your retention period is, let's say under state law, is 10 years for a medical record, if somebody asks for it, it doesn't matter if you stored it. It happened 9 years ago or it happened today. If the patient's record has not been, you haven't gotten rid of it, then you need to be able to provide access to the patient or the health plan member. Now, designated record set, one of the things that would be nice is if early on they'd actually put out a definition of it, but this gets a little bit closer to what the Office for Civil Rights is saying is a designated record set. And here's some of the things that it includes. It includes medical billing records, includes all those activities that you have with the health plans, including case management or medical management, and other things that you use to make decisions about the individual's care. This could be records about something that, an example here where it says basically you didn't use it to make a decision, but you put it in the medical record. That would be part of that is, as an example, if you go to your state's prescription drug monitoring program database and you download a report on a particular patient and the prescribing record, but you don't use it for the appointment, you don't really even look at it, you just download it and stick it in the EHR. You didn't use that to address patient care, but on the other hand, you did access it and you did put it into the patient's record, so that would become part of the designated record set. And another area that has been somewhat of a myth over the years is, well, I got it from a third party and therefore I don't have to give that to the patient. They should go over to the third party and ask. Once you make it part of the medical record, it becomes part of the designated record set. So it doesn't matter if it says a document from a referring provider or you're referring somebody else and you get more feedback to put in the chart. If time you put it in the chart, with very few exceptions, that becomes part of that designated record set. Now, here's a little bit, I just went through this, but just to emphasize as far as records that are made to make decisions about folks, is if you're using something, wellness tools, prevention tools, all those kinds of things that you're going to incorporate into your medical record, those need to be part of that designated record set that you're providing to patients. This is not including if somebody has a personal health record and they say, Doc, I want you to download my designated record set into my personal health record. You don't have control over that personal health record, so therefore you don't have to worry about making a copy of it, because the patient is basically responsible for that. Now, individuals have the right to a broad array of different types of health information about themselves maintained by or for the covered entities. So when you're responding to requests for access, you're not required to create additional information like explaining to them what is in the designated record set or perform some sort of analysis on it. If it doesn't exist in the designated record set, you are not required to create it. Now, you could if you chose to, and in some situations you could even charge for that. But In the end, that's not a requirement if somebody asks for the designated record set. Now, some of the things that are actually excluded from the designated record set as far as a right to access, if the PHI is not part of the designated record set because it's basically not used to make decisions about the individual. In other words, I didn't put it into the medical record. Things like quality assurance, quality medical management, patient safety activity, business planning, all of those things that in a lot of respects fall under that healthcare operations category, those are outside of the designated record set. Psychotherapy notes, by their nature, they're created outside the health record and generally kept outside of the medical record. Those are specifically excluded. And information, if you think you're going to get sued, in other words, you have somebody that's either said they're going to sue you, you got a subpoena, whatever, you can withhold that for that civil or criminal or administrative proceeding. Now, who can request a copy of the designated record set? The individual, of course, the patient or the health plan member. Now, personal representatives can request it. Now, with a personal representative, there's no definition in HIPAA really of what a personal representative is, other than there's somebody who can speak on behalf of the patient, and they basically have the same authority as the patient as far as patient rights, things like that. That's generally defined under state law. We're looking at things like power of attorney, healthcare power of attorney, guardianship, like with state agencies such as foster care. And in most cases, in states, the parents or guardians of minors are considered legal representatives. And that's one where you do have to be careful because there are a number of different state laws. They're not really consistent from one state to another that you need to pay attention to because, as an example, in the state of Oregon, if a minor goes in for a test for sexually transmitted diseases and they're being treated for it, that is basically their record. They're at the age of informed consent, and mom and dad cannot look at that record unless the minor provides an authorization. And there's a hodgepodge of those types of laws across the country. The other area where you can basically say, I'm not going to honor the personal representative's request is if you suspect there is abuse that's occurring, and the personal representative is the perpetrator. Now, as far as access, this is one that's also somewhat of a myth. It's been said many times over the years that if a person wants their medical record, they want their designated record set, they've got to do it in writing. Well, that's a may. You can require them to send it to you in writing, but that's not a HIPAA requirement. That's a may do it rather than shall do it. So they can request it in writing. The point here, though, is make sure you've got that information in your notice of privacy practices to inform the patients up front to say, if you want a copy of your record, this is how you go about it. They may give them the option of using electronic means to request a copy of that, email, secure web portal, things like that. And they also may require individuals to use their own form, but to keep in mind that that's only if it does not create a barrier to or a necessary delay as far as getting that person access to their designated record set. And I'll go into that in a little bit, or a little more detail as we move along. Now, covered entities, they need to take reasonable steps to verify the identity of the individual. They need to make that effort to say, okay, you're standing in front of me, show me photo ID, you're on the phone, I'm going to ask you some questions about like your address, your birth date, maybe the last four of your social security number, so I can validate who that individual is on the other end of the line or who's standing in front of me. You can't mandate any specific form, the privacy rule doesn't mandate any specific form of verification. In other words, it's left up to the judgment and discretion of the covered entity. And what I would advise when it comes to this kind of thing is make sure you document what kinds of verification that you're going to require and the different scenarios, like in person, over the phone, via email. And then make sure that your staff know about it, because that's sometimes an area of confusion, especially for the patients, because they will come in and the staff don't really know what they need to ask them as far as for verification, and that can be real frustrating for the patient. Now, the verification can't create barriers on unreasonable delay as far as the person getting the access to the patient information. As an example, you cannot require a patient to go down to the bank, get their the form notarized to basically prove that they are who they say they are. That would be considered an undue burden on the patient as far as getting their medical record. Now, it can be orally, like I said, in the phone conversations. It can be in writing. However you do it, it's a good idea to, say you take it over the phone, you validated the individual. It's a good idea to document that to make sure that it's in the record that this is how this request came in. Now, the type of verification, it's going to depend on the individual when they're requesting access, how they're requesting access. And that's something I've already talked about having different scenarios like on the phone or in person or via email. Now, a covered entity, they can impose unreasonable measures, and I talked about the example of going down and getting the notarized form, for example. Another example of this would be, say a person wants their medical record mailed to their home address, you requiring them to physically come into the doctor's office to request access and provide proof of identity in person. That would be an undue burden, especially if there's a significant difference between your office and the patient's or the health plan members. You also can't require them to use a web portal for requesting access because still in some rural parts of the country, there is no internet access. And then there are also, especially when an aging population, there are folks out there that just don't use the internet. So you can't force them to use the internet to access their medical record. Now, another example is you can't require an individual to mail an access request form, or excuse me, you mail it to them. And that's one of those where OCR is saying that could create an additional delay for them getting access. So if they've got access to email, you could email the form to them. You can fax it to them. There are other ways to get that form to them rather than saying, I'm going to stick it in the mail. Now, one of the things that you can't do when you're a covered entity is you can only have one way that information can be accessed. This sort of gets back to the examples of my only one way to request access is to come into the office and show me your identification. That can't be the only way. And so it's being encouraged by the Office for Civil Rights to look at multiple options, and this gets back to what I was talking about as far as documenting what those methods of access request are, verification are, and then educate staff as far as what the requirements are, or what your procedures are. Now a little bit about the form and format and the manner of access. The individual who's accessing or requesting access can say, I want it in this form or this format. They can say, okay, it's going to be electronic and I want it in a PDF or I want it in a Word document. So they can request different forms of the way that you're going to present the data to them. That's not something that's going to happen all that often, but if they are savvy and they really know what's in the rule, they can do that. And then if it's easily producible in that form or format, then you provide it to them. If it's not, you provide them a readable copy or some other form or format. And it says as agreed to by the covered entity and the individual, but what it gets down to is if, say, the covered entity can only produce a PDF of the medical record or an electronic copy of PDFs, then sort of the individual is somewhat out of luck if you're saying, I'm sorry, I just can't produce it, because the other thing is that you don't have to go to this huge additional expense to buy special equipment to produce the designated record set in whatever format the individual requests it in. So if they ask for it in an electronic form, then you need to give it to them electronically. One of the other things that OCR spoke to in the guidance, which is taking a step a little bit further than when the omnibus rule came out in 2013, is what they said is if it's easily made electronic, then you have to make it electronic to them electronically, such as you can scan it in, it's readily producible, then you need to make that available to the individual, and we get into form and format again. So it again, it says you must agree on the form and format. That's great from a technical or regulator's perspective. It's not necessarily going to work in all cases with patients. Now a bit about paper records, and this is one that I want to emphasize again, is that if you can get it into the record, you need to get it into the record. And that doesn't mean you need to go out and scan all of your charts. Say you've you've converted from to an EHR and you've got older charts that are been archived off-site, you do have to provide them copies of that information, but you don't necessarily have to go out there, get all of those documents, and just scan everything in. This would be sort of on a case-by-case basis. So it's readily accessible and you can easily scan it, then you need to do that. And if you can't, then you need to provide them a readable alternative hard copy format. Now, it's one of those that gets back to emphasize you don't need to go out and buy specific new software equipment to accommodate everybody's request, but you do need to be able to produce an electronic copy if you have an electronic medical record or some other form of electronic storage of the medical records. Now, if the individual says, oh, I don't want that electronic format, I don't want a PDF, I want it in Excel, then the covered entity can provide a hard copy. So that's basically the alternative. If you can't agree on an electronic copy, then the covered entity can revert to hard copy. Now, when you're providing access, one of the things that you can do instead of providing them a full copy of their designated record set is you could provide them a summary of the designated record set in lieu of providing access to the full designated record set. And that's something, just as with obtaining a copy of a designated record set, if there are costs associated, you need to communicate that up front, whether they're getting a full copy, whether it's only a summary. You can also, if they say, I want you to provide me an explanation of what's in my record, so somebody has to sit down and review the record and take notes and create a document for them, that's an explanation. You can charge for that. You just, again, need to let the person know in advance that you're charging for that. And they have to agree to get the summary or the explanation, and then they also have to agree to any of the fees that are associated with that. Keep in mind, they can also say, well, I don't want to pay for it. I'll come in and you can let me look at it, and they have that right to do that, and you can't charge them for that. And things like the person says, I want to copy my record, you need to work with them as far as how to get that to them, such as arranging a convenient time and place for them to pick up that copy or to view it, whether you're mailing it, emailing it, providing that copy of the designated record set. So it needs to be provided to the individual in that manner. Well, covered entities aren't required to accept unreasonable risks in providing copies that are transmitted to the individuals. It's things like you don't have to provide them a network login, or you don't have to let them sit down at the electronic health record and log in for them and basically let them do their own thing. That would be considered more significant risk than you're required to accept. Now, OCR does expect covered entities to email the request if that's how they request it and the file size isn't too large. So that's something to keep in mind, is if somebody says, I really want my designated record set emailed to me, if you got it in electronic form, you have to accommodate their request. This is one of those exception areas when it comes to the rule itself, where if you explain to the patient or the health plan member, here are all of the risks associated with sending it over the internet, and they sign on the bottom line and says, I don't care, I'm going to accept the risk, then you can send it to them unencrypted. You can still have a policy, though, something more stringent than HIPAA, and basically say, no, I'm not going to, I will email it to you, but I'm going to send it to you encrypted. Because keep in mind that vendors like DataMotion can provide support as far as sending much larger attachments than most email systems. And there are vendors out there to take a look at, but that one of the good things about it is you do have a method of easily getting larger files to the patients that, say, in your regular Microsoft Outlook, it would be an attachment that would be too large to send to somebody, especially if it has things in it like images. Now, OCR does expect covered entities to use a secure method of emailing the copy of the designated record set. There is that exception, but if you're not going to accommodate that, you have to encrypt it. It's one of the things that OCR has been hammering on for the last 2 or 3 years is you need to encrypt it. If you're not encrypting email, they don't see that as acceptable, and we're pretty emphatic about it when the CLIA HIPAA bill came out in the beginning of 2014, where they said, This is the only exception. They consider encryption to be reasonable. So even though the security rule says encryption is addressable, the regulators are looking at it more as required. Now, the cost of an email solution is really within the budget of all covered entities. That includes data motion solution. You can find all shapes and sizes out there that will support the, say, the single physician practice all the way up to the multi-state health plans. So there are some solutions out there that are not outside of the budget. And just getting back to the fact that if you do accommodate unencrypted emailing, make sure you've got it very documented that that's what you're doing, because if a breach does occur, you don't want the patient to come back and say it was your fault. Now, you have 30 days. So you get a request for a copy of a designated record set, you got 30 days to respond. And one of the things that OCR emphasized in the guidance is that's an outlier. You need to provide it to them as soon as you possibly can, and not wait the full 30 days to provide them access. And the way they look at it is we're moving to an electronic world where accessing the patient health information is easily available. You can push it down to health records. You can make it available through web portals, things like that. So it's becoming more of a process that's almost instantaneous in some respects. But it's making sure that you are giving it to them as soon as possible. Now, there is an exception to that. If, say, as an example, you've got those charts that are archived way across town and they're buried in a box somewhere, you do have an additional 30 days in order to pull that out. This is really an exception, but you can, as long as you tell the patient or the health plan member that you need that additional 30 days, and you have to tell them that within the first 30 days. So you need to tell them, and you need to do it in writing, explaining why it's been delayed, and you also need to let them know when they can expect that a roundabout date, rather than just saying, oh, we just want another 30 days. OCR is saying if you need to extend it, you have to tell them why and when they can expect a copy. Now, fees for copies. This is something that OCR went into in a bit more detail. You can impose a cost-based fee if somebody requests a copy of the designated record set. But the fee can only include the labor of copying, whether you're making it electronic, you're saving it off on media, you're printing it off, the supplies for creating the paper electronic, such as USB drives or CDs, postage, where you're mailing it to somebody, and then if the patient agrees to preparing that explanation or summary of the protected health information, if that's what's agreeable to the individual. Now, also, what it can't include is it can include the cost of verifying who that person is. Can't do what I would call the paperwork side of things or documenting the record. You can't charge them for going across town and digging through that box to find their old paper chart. They're not going to pay for your back-end maintenance of your systems or recouping capital for data access, storage infrastructure, all those costs that are are expenses that are associated with maintaining a patient record and providing copy to that record. You cannot provide or charge them for that, even if it's allowed under state law, because in that particular case, HIPAA would be the more stringent law and would trump the state law that allows you to charge certain things for certain things that HIPAA does not allow. That gets into what OCR calls contrary. And I'll talk about that in a little bit too. Now, what you may do is you can either calculate the actual cost right up front and say, this is how much it costs me to provide an electronic copy, or this is what it costs me to do a paper copy, and you do that each time you create a copy of a designated record set. You can also use a schedule of costs based on an average allowable labor cost. So you can say, okay, on average, it costs me this much to make an electronic copy. Therefore, that's what I'm going to charge individuals. Now, what happens if you don't want to do either one of those? You don't want to calculate the actual cost, or you don't want to develop that schedule. You can charge a flat fee, and that flat fee, inclusive of everything, cannot exceed $6.50. Now, when that came out, there were a few people that came unglued because it sounded like OCR was saying you can only charge $6.50. And so OCR came out with additional guidance saying, no, that's not what we meant. So it's one of those where, I'll get into that in more detail in the next slide, but that's one of those where OCR had to clarify itself. Now, in cases where you elect to use that average cost or a flat fee, if you get an unusual request, you get a request that requires an extra 10 gigabytes of images or something like that, where it's going to take, let's say, a larger USB drive to store all that information if you're sending it to them on a USB drive, then you can charge additional for that, keeping in mind that you need to make sure that you document, this is what I charged and this is why I charged this amount, so that if somebody comes back later and says, you know, why did you charge that amount, you can explain why you deviated from your standard approach as far as charging for copies of the designated record set. Oh, I think I forgot my slide here. I'll go back to this one and talk a bit about the $6.50. It's one of those where what became confusing to folks is they saw that, and then when OCR provided the additional guidance, OCR basically said, we're not saying that's all you can do, we're saying that's one of your choices. So you have, again, the three choices. I can calculate the cost of creating that designated record set each time, I can calculate it on an average, or I can charge a flat fee. Now, as the denial of access, there are some things that you can say to a patient, I'm sorry, I'm not going to give you access to that. First one on the list is getting back to psychotherapy notes and then information compiled for use in a legal proceeding. Those you don't have to provide them a copy of it. Just keep in mind that after the legal proceeding is over, you can't withhold that information to the patient or health plan member anymore. So it's one of those that there is a cutoff date when you can basically hold that information back. Another exception is with inmates. If they're entitled to view their record. So if they want to look at their record, then the correctional institution or health insurance or healthcare providers that are providing services to or treatment to those inmates, they have to be able to, the inmates have to be able to be allowed to view their record. Now, they don't always have to be allowed to get a copy of their record. If the institution basically says, I think that's going to be, providing them a copy is going to be danger to that inmate, or it's going to be danger to somebody else in the prison, whether it's another inmate or it's a guard, then they can withhold that copy of the designated record set. They still retain, again, the right to inspect their designated record set or view. Are there unreviewable grounds for the denial? If the designated record set is part of a research study, so if a patient up front agrees to, say, a clinical trial for research, then that information, the related clinical treatment that's associated with that research, that information is basically not available to the patient during that research study. One of the changes that happened with the passage of the omnibus bill, or the finalization of the omnibus bill, and also was in high-tech, was around research. And one of the changes that was made is that, guess what, your event could be indefinite, or it could be infinity, it could be death. So in research studies, there may be authorizations that basically say, or that I'm signing up for, where I'm saying this authorization never ends. In other words, the research is going to be ongoing for, say, 20 years or so. That, in essence, shuts that information off from the patient because the research has not been completed. Again, they have a right to have that information after the research is completed. The other thing that you cannot disclose, or you don't have to disclose, are things that are around, like a federal agency, secret information, things that are protected under the Privacy Act. You can deny that access if that's basically consistent with the Privacy Act. In other words, the Privacy Act says you can deny access for these things, and that's what you're doing. As with everything, document the heck out of it. The last unreviewable ground is if somebody comes to you and they say, I'm going to tell you something about this patient. It might be a spouse, boyfriend, girlfriend, child, whatever, and they come and say, I'm going to tell you this. I'm going to provide this information about this patient, but you can't tell them I told you, because they know exactly where it came from and they would be angry with me. I just want to make sure they get the best care. And if you agree to accepting that information in confidence, then you have to keep that out of the designated record set. There is no appeal. The patient can't come back and say, hey, I really want to know who told you that. You don't have to let them know about that. Now, reviewable grounds for denial. The access request is reasonably likely to endanger the life or physical safety of an individual or another person. That's one of those where it is appealable if it doesn't extend to if you think that the person won't be able to understand it, or you think that it might make them upset, angry, whatever. That's not something that falls into that category of endangering life or physical safety of the individual or another person. So it's one of those where you really need to be careful on that one. What happens if they say, I disagree with your decision not to provide that to me, they can appeal that, and that would go to likely another healthcare professional within your organization. You don't have to go outside to have that second opinion done. Another reviewable grounds is if there's the access is reasonably likely to cause substantial harm to the person referenced in the PHI. So in other words, somebody's name is in the record, and you've taken information, not where it falls under the confidential information, but you got somebody else's information in the medical record for whatever reason, and you can deny them access, but they also have the right to appeal to that. Same thing as threat to harm another person. Now, if the access is also reasonably likely to cause significant harm to the individual and other person if it's accessed by the personal representative, that's appealable, just like if the patient were asking for it. Now, one of the things that covered entities cannot do is they cannot ask somebody, well, why do you want a copy of your medical record? And even if the person says, hey, I want a copy of my medical record, I want to take it out and post it on Facebook, you can't say, I'm not going to give you access to your medical record because you're going to go post it on Facebook. They can go do whatever they want. People do that all the time on Facebook. So it's one of those that even if they say, I want to build a bonfire with this or whatever, you have to provide them a copy of that information. That's not an excuse not to provide them a copy. And you also can't deny access if you got somebody else storing the information for you. Say it's, as I mentioned earlier, about the off-site hard copy storage, or if it's maintained in your EHR, things like that. It goes back to my example of when I asked for access to view my medical record, and they say, well, you can't because it's in the EHR. That you can't deny access just because of that. Now, if the covered entity does deny access, whether it's full denial or it's partial denial, that needs to be communicated to the patient within that first 30 days of the request. So you need to respond to that just as quickly as you would providing them a copy of their record. You need to explain it to them in clear English, or in some states, if you have to do translation services, like because of the population you serve, it needs to be in readable a document that they can access and understand. And then you also need to explain to them how they can request a review. And one of the things that's oftentimes left out is you also have to tell them how they can file a complaint to the covered entity, in other words, your privacy officer, or to the Office for Civil Rights. Now, if you don't maintain that particular record, but you know where it's at, you know that the person likely is referring to the doctor that might have referred him over to you, so you know that there may be medical records there. If you know where the records are, then you need to inform the patients as far as where to go to request copies of that, and then give them access to all the other PHI that you have. And if you have difficulty segregating all that, because you say you had a medical identity theft issue and somebody else's information got into that patient's record, just because it may be difficult to segregate the information doesn't mean you can't say, I'm going to deny access for that. Now, as far as review of the denials, if the denial is considered reviewable and the individual seeks a review, that's one of those you need to promptly refer the request to the reviewing official, which could very well be somebody else who works in your organization. It doesn't have to be an outside third party that's independent of you. It can be somebody that works down the hall. They need to make a decision in a reasonable period of time whether they're going to say that denial basically is withheld or upheld, or no, I think that denial should be reversed and they should be allowed access to their information. So they need to do that relatively quickly, and then following that, the covered entity needs to notify the individual relatively quickly. Now, an individual has the right to direct, this gets the third-party rights, have the right to direct the covered entity to send their designated record set to a third party. Now, it needs to be in writing. It needs to be signed by the individual. It needs to really clearly say, this is who I want it sent to, and this is how I want it sent to them. So it's basically identifying all of the information that you need to verify that the individual wrote it, and you have all the information you need to provide whoever they want to send a copy to with a copy of that. You can't charge any more than you would charge the patient. You can accept it electronically as long as it's electronically signed, whether it's through a secure web portal, they sign a PDF and send it to you electronically, but it has to be in writing and signed. Now, state laws, I'd like to talk a little bit about state laws, because state laws, as I mentioned earlier in the presentation, that state laws can sometimes wreak havoc with HIPAA if you're not paying attention to the state laws, because they're this hodgepodge across the country. I work in a number of states, and we have to look up the minor laws every time we're in a different state because they vary so much if we're dealing with minor vendors that deal with minors or covered entities that deal with minors. Now, the other thing state law may do, actually, let me back up. I've already talked about greater access to information. One of the things I'd like to use as an example is if a covered entity is subject to a state law that says the person has access to their records, say in 10 days versus 30 days, you have to accommodate the shorter time period. So that's where state law would trump HIPAA. Now, unless there's an exemption in the HIPAA rules, state laws that are contrary to the privacy rule, their access provisions, such as the CLIA exception that still exists in some states, which is you can't provide lab tests to individuals until they've actually been reviewed and read. That was trumped basically by the HIPAA CLIA rule that came out in 2014, which basically said it doesn't matter if the individual wants it, you have to make them a copy of it. So that's the kind of law that would be where HIPAA would preempt state law. So it's really important to know what your own regulatory environment is, especially if you operate in more than one state. Now, one of the things, just as a sort of a side note here, OCR did announce that there were going to be no on-site audits, but they did say that they would continue with the desk audits. What does that mean? Well, that means that those areas that I talked about towards the beginning of the webinar about the right to access, a notice of privacy practice reviews by OCR, that's going to continue. So this is one of those areas that has been and will be a focal point of the Office for Civil Rights audits. I would also expect the audit protocols, just as with some other state agencies or federal agencies that have created them, those audit protocols will start being used for things like investigations. So you will see more of an emphasis on the audit protocols, I believe, in the future. So, and that's one of the things people ask me, say, well, how likely is it I'm going to get audited because they audited so few? It's probably not very big, but on the other hand, if you have a breach, you might be investigated for this, or you have a complaint file. OCR does look at the complaints, and unless it's really out there or it's outside of their jurisdiction, they do investigate all of those complaints. So it's one of those that you don't want to find yourself in a position where you're not following the guidance, and basically OCR comes back and says you're guilty of willful neglect. Here's your fine. Now, in summary, it needs to be easy for patients and health plan members to get a copy of their designated records. That you can't make it too hard for them. It needs to be accessible, and it's a really good idea. I would really recommend making sure that your Notice of Privacy Practices has defined in it how patients can exercise those rights, like how can I request an amendment, how can I ask for a copy of my medical record. You need to know up front what you're going to charge for a copy of the designated record set. Do that in advance, whether you're using the per incidence, I'm going to calculate it at each time, whether you're using an average or whether you're using the infamous $6.50. You need to know that up front. And one of the other things that has been somewhat of a discussion around is I've heard folks say, well, if somebody wants to send their third-party letter or they want their designated record set to somebody else, then I'll just use the authorization form. Well, that's not the right form for it, because an authorization form is very prescriptive, and there are certain elements that have to be in it. It's intended to be sort of an outbound type of a thing where somebody's saying, I want this information sent to somebody else. The access request where you're sending it to a third party is also prescriptive. It's, as I indicated, it's got to be in writing. It needs to clearly say who that information is going to, how the contact information, all that wonderful stuff with a signature at the bottom. Those are some of the things that are in that kind of form versus an authorization form. Now, a few resources for you. Here's a link to the Office for Civil Rights Right to Access Guidance and their associated FAQs, a link to the OCR Model Notice of Privacy Practices. State laws, this is circa 2013, so it's probably changed. State law seems to change every time legislators come into town, but this will give you an idea of what's happening across the country. One of the things that it does require is registration. It's not obnoxious. There is no cost to it. It's actually a pretty slick heat map of what the state laws are. So it gives you sort of at least a starting point when you're looking at it and saying, hey, my state has some laws that may trump HIPAA or the other way around. And then the American Health Information Management Association published a publicly available model access request form that you can take advantage of. With that, I'd like to turn it back over to Bud.
Great. Thanks, Chris. Can you hear me all right?
Yes.
Okay, good. Really appreciate that. Very informative, and of course, we all appreciate you sharing your expertise with the folks on the webinar. Always happy to work with you. Before we move on to Q&A, and it looks like there's quite a few questions in there, Chris, so if you want to review them, I'm just going to take a moment to familiarize our audience with DataMotion and also give a quick perspective on making electronic patient health records available in compliance with HIPAA. So DataMotion, we're a cloud services software vendor. We're focused on the development and delivery of secure data exchange services, and we've been doing that since 1999. Microsoft Gold application partner, and we primarily focus on industries under compliance like healthcare, financial services, insurance, and government. And our solutions are things like secure email, email encryption, secure file transfer, direct secure messaging, specifically for healthcare, and secure digital workflows, kind of stitching into high-volume workflows where compliance is required and encryption is required. We're active members of a bunch of trusted exchange associations, particularly in healthcare, and we've provisioned about 5 million users on our services platforms over the years. You can see some of our enterprise-class customers like Berkshire Hathaway's Guardian Insurance and University Medical Centers like the one here in Hackensack and the state of New Jersey, among some other large states that use our services. Some OEM customers listed there too, such as Sonic, Wall, and Varian. So if you're looking to do a better job of exchanging sensitive information and making sure it's secure and compliant and doing it efficiently and cost effectively, I encourage you to visit our website and consult with one of our experts. But just to give you some perspective on online access to health information from DataMotion, when we look at the need, as well as the HIPAA requirement to give patients access to their medical records, we kind of start from the current landscape. Most of the doctors and diagnostic labs out there now are using some kind of electronic system, electronic health record system to store our data, right? And most of those EHR systems have patient portals. That's kind of the first thing they stood up, and there you can log in and view most of your record, if not all of it, and download it. And there's also regional health information exchanges, and they attempt to consolidate your patient record, your electronic record from all the different doctors and hospitals you may visit. So those are great resources, and to us they kind of represent the pull method of getting your information. You go there, you log on, you search, and you pull it down. And as Chris noted, it's not for everybody, and it frankly puts more work on the patient and skills on the patient to do that, but it's a very effective way to get information. And overall in the life cycle of electronic health records, these pull options are really the dominant way. I mean, this is the first way that's offered to retrieve patient health information electronically. Register, log on, find, pull the data down. and download the files from their system. So the alternative, of course, to a pull method is then a push method. A push option means, delivering the health record to the patient. And historically, that's been by hard copy, and in some cases, sent through the mail or sent by a fax machine. But now in an electronic medical record world, printing, mailing, faxing, they're really, inefficient and kind of costly methods to do things, even though they're, widely used still. So, we see what makes more sense today in an EHR system world, electronic health record system world, are really low-cost, secure messaging services like email encryption and direct secure messaging, and even some simple but secure file sharing for things like large diagnostic images and large files. So, what patients really want, they want, both the push and pull capabilities, and some of them want them in like mobile health applications. So you can kind of pull the health record information from that application and then maybe push it somewhere else, that information securely, and, again, in compliance with HIPAA. We see classic examples of that where a mom wants to retrieve a physical exam report from the doctor and then send it on to an athletic program as part of their registration and approval process. So these are all, very, very doable, whether it's as simple as an encrypted email or something more sophisticated as integrated into a mobile application. So that's kind of where we see this kind of yin and yang, and that symbol comes into play. Both the pull and the push techniques are needed and useful and needed to make patient health information widely accessible, and to do it cost effectively and in time efficient ways, well within that 30-day window, and really to reach the greatest amount of patients and the families and their caregivers, enable them to share across their care teams, and done all in compliance with the security privacy rules, as well as that 30-day rule of giving patient access to the information. So again, here at DataMotion, we kind of specialize in making easy-to-use push techniques and services available to healthcare providers, to patients, to healthcare solution providers, and do it as kind of a seamlessly integrated service at times. So again, please call on us if you'd like to learn more about that. So back to Chris and to your questions now, as we've got a few minutes left in the hour. Chris, do you have a chance to look over some of those that are in the panel? I did. Do you see one that jump out that you want to start off with?
Oh, let's start off with I hope it's an easier one. It's the first one, which is that I'm seeing up at the top, which is where can I find a HIPAA form for authorization. What I'd recommend is just go out to Google and type in authorization HIPAA, and you'll come up with some links to not only the Office for Civil Rights, but there are different types of authorization forms that are out there that you can take a look at. So that's where I'd recommend going to. Now, one of the things, another question that was asked is if a third-party requester whom I've designated to receive my designated record set, do they need to respond in the same time frame as if responding to the patient, such as I need my medical records sent to a life insurance company? That's one of those areas where OCR is silent. They did not address that. But what I would say is it's really a good idea to follow the same guidance when you're sending it to an individual as you would when sending it to a third party. So if you need to get it to them in under 30 days, or you need to deny access, then I think you need to be able to provide them that. Another question is, what should I do if my records are not provided by my third-party requester after 60 days? What you need to do is contact the covered entity and say, did I miss something here? I need a copy of that record sent to this individual. And then if they are unable to provide it or unwilling to provide it, I'd recommend filing a complaint with the covered entity as well as the Office for Civil Rights. Another question is, if you got a copy of your records and you want it sent to a third party, say you're applying for life insurance and the office uses a copy service, how much time do they have? Well, they should get that to you in under 30 days. A lot of folks don't abide by the rule, I agree, but that's one of those where, what I recommend is patients push back. And in some cases, unfortunately, patients don't know they have the right to push back, but that's one of those things that I'm really pretty strong on, is that if the patient wants access to their record or they want it sent to a third party, you need to be able to follow the rules and get that copy out as soon as you can. Another question was, what's the definition of reviewable? Reviewable means that, another way to look at it is appealable. So if you say, my medical record, or the medical record you can send to me, you're withholding certain parts of that, like threat to self or others, then I, as the patient, have the right to appeal that, and then it needs to be reviewed by another healthcare professional to either say, yes, the denial stands, or no, you need to provide them that copy of the medical record because I don't think it is a threat to self or harm. Yeah. Now, the rule on electronic health signatures when sending an authorization or HIPAA form to a facility, what is the rule? Most states have an e-sign law, and there is also a federal e-sign law. So it's looking at, as an example, using something like DocuSign or something like that to have them electronically sign it. You may have the capability through your portal, and you may choose to, if somebody sends you they had the paper form, they signed it, they made it a PDF, and they sent it to you electronically, you can also say, hey, that's a valid signature. Just it's always a good idea to make sure within your own regulatory environment you're following the rules around like e-sign. Now, one of the things that I was asked to do at the end of the webinar is to reiterate other physician records. So you send them out when you refer the patient out, when the insurance company asks for it, when the patient asks for it, if third-party requester asks for it. Currently, it's one of those things that you can't say you're going to send it out to somebody else. Now, if you're looking at, say, you get a request from an attorney, it's not a subpoena, it's an authorization signed by the patient. If that's the case, then you need to send them whatever is specifically included in that authorization, because where feasible, that's supposed to be something specific. Now, if the attorney has them sign it and say, well, I want everything, that's a good idea to follow up with the attorney and say, well, what do you really want, rather than just blanket, I'm going to make a whole copy of the file and I'm going to send it out. The same is true, like you're sharing records with, say, an insurance company. That has to meet the minimum necessary requirements. You can only provide them basically what is needed to respond to the request. When it comes to other physician practices or healthcare situations, if you're, say, sending information over to a referring provider, that's the place where minimum necessary does not apply. It is a good idea to only send them what you believe is necessary, but there is no requirement to say, well, you can't send any of that, or you have to deal with minimum necessary, because sometimes that can get in the way of a treatment relationship and have adverse patient outcomes. So it's a good idea to make sure that you've got all of those things defined in your policy, so when somebody asks for a copy, you know what you can send and how much you can send. The lawyer suggested this additional measure as dollars in question to avoid patients suing us for their money or case, etc. Not quite fully following that, but I see what you're saying. They want to know, they currently require the patient to complete their release in addition to what the third party sent us. As long as it doesn't get in the way, then that's not a problem. But if you have a third party asking for something, and then you go to the patient and say, well, I need you to sign an authorization, if it delays them getting the information, if it falls, first of all, if it falls under sending a designated record set to a third party, you really can't do both. You do need to determine who's making the request. So if a patient takes a form requesting third-party access, say it's your form, and they take it over to their attorney and give it to them after they've signed it, and the attorney sends it to you, then the patient is actually initiating it. In most cases, when attorneys are sending you something, they will either use a subpoena or they may even use an authorization. In those particular cases, you go by what's in the authorization or what goes into the subpoena. And this sort of falls into the category of, even though you're not required to, Many practices, hospitals require the patient to sign an authorization before releasing information. That's not getting in the way. That's not an issue with right to access because it's for a specific purpose. You can make them use your form for that authorization. You can, there are different rules that apply when you're looking at an authorization versus accessing a designated record set versus, say, a subpoena. And yes, I agree that will probably save you a bit of money and time, and anybody can sue over anything, and even though you're allowed to do it under law, that doesn't mean somebody's not going to sue you for it. So if you can take that extra step, that's great. Just keeping in mind that if it is truly a designated record set copy, that falls under the HIPAA definition, and it's the individual who's accessing it or wanting access to it or send it to a third party, then you need to follow the rules that are set out in the guidance. Now, one of the questions is, are we required to release records when patients are in-house and records are incomplete? That's a good question. I would say that the answer is yes, if the patient is requesting it, if it's in-house, because it gets back to the CLIA exception under some state laws, but it's not under HIPAA. It used to be that if the lab hadn't been reviewed by, say, the radiologist yet or the doctor yet, then you could withhold that information from the patient until it was reviewed. That changed in 2014, and it basically said, no, you can't do that anymore. So if it's incomplete and somebody's asking for it, you still need to provide them a copy. I would say you probably want to say it's incomplete so that they know that.
Great.
Are there any other questions?
Yeah, I think that that rounds it out, and I know we just pushed past the top of the hour. So again, I want to thank everyone for joining us today. We had a great group on, and obviously a lot of good questions for Chris. Also want to thank Chris, as always, our expert in being able to put this information together and deliver it in such a great manner for us. So,
thanks, Bud.
Yeah. So thanks again, and we'll hope to see you all next time on the next DataMotion sponsored webinar.
Thank you, everybody.
Take care.